Hello everyone, my name is Christian Romero. For this week, I'm going to be presenting a 55-year-old female Hispanic patient presenting to the clinic with a shift complaint of urinating a lot lately and feeling very thirsty. So the symptoms initially started 2 weeks ago, but symptoms aggravated for the last 3 days. Patient has not seen a primary care provider for the last 2 years and is also here for establishment of care. Patient denies any pain upon urination, any false smell, any blood in the urine, any chills, any vaginal discharge, or urinary frequency. The last pap smear and mammograms were done last year with no abnormal findings. Past medical history of hypertension. Patient is already in postmenopause. She had a C-section when she was 20-year-old. No complications during when delivering. She's not allergic to any medications. Currently taking acetaminophen 650 milligrams oral every 6 to 8 hours for pain, and captopril 25 milligrams twice a day. Vaccinations are up to date, and she received the flu vaccine last year in November. Family history of hypertension and type 2 diabetes on her maternal side, and paternal side also DM, type 2 and hypertension, COPD, and liver cirrhosis. She denies any smoking, any alcohol or substance abuse. She is married, agricultural worker. Diet consists of fast food approximately 6 to 5 times a week due to long periods of work. Diet consists of high carbohydrate and high fats. Current sleeping about 5 to 6 hours a day, but it's being changing lately because of the constant waking up for the need to void. Patient reports dry mouth, being thirsty, and dry gums. Denies any weakness, numbness, or any loss in sensation on the lower extremities. Patient vital signs: heart rate 88, blood pressure 129/77, respiration rate 17, pain 0 out of 10, temperature 98.7. Oxygen saturation 100% room air. She is 5 feet 7 inches, weighs 230 pounds, with BMI of 36. So for this patient, we did in-house lab works, which showed random blood glucose of 198, A1C of 8.4. We also did a urinalysis, and she's negative for bacterial, leukocytes, nitrates, ketones. Specific gravity was 1.018. Patient does not have any tenderness or suprapubic region or CVA region. She has delayed skin turgor. Sensation is present intact. Normal monofilament examination. Regular S1 and S2. Breath sounds clear and equal bilaterally. So for this patient, our diagnosis was type 2 diabetes based on clinical manifestations of the patient, and also supported by the A1C of 8.4 and the random glucose 198. Patient also has a strong family history of diabetes. Patient is obese with BMI of 36. Another diagnosis was dehydration due to the increase of urine depletion that the patient had, and also the poor skin turgor of the patient. So for the plan for this patient was the A1C, did a urinalysis, random glucose test. I also ordered a CBP, CBC lipid panel, the liver and thyroid panels, and the patient to come back to the clinic for results. in 1 or 2 weeks. I initiated metformin 500 milligrams twice a day, and patients will increase to 850 twice a day if the blood sugar still remains above 180, and also to avoid any gastric upset. Recommended patient to take metformin with meals for the same reason, to avoid any gastrointestinal symptoms. Also made a referral for the patient to see ophthalmologist for annual eye exam. And again, patients return to the clinic in 1 or 2 weeks for reevaluations of the symptoms, and patient to bring a home log with blood sugar readings. Thank you very much.